Hello everyone, welcome to the latest webinar from our Queen Elizabeth Scholarship Program in Strengthening Health Systems, brought to you by the McMaster Health Forum at McMaster University in Hamilton, Ontario, Canada. As an agenda for today's webinar, I'll provide you with a little bit of information on the McMaster Health Forum, the Queen Elizabeth Scholarship Program, and the current version of the scholarship that's offered here at the Forum. I'll then turn things over to our incoming scholar presenter, who is Pippy. She's visiting us from Australia. She's going to be talking about the work that she's been doing on chronic pain in primary care. Here at the McMaster Health Forum, we aim to be the leading hub for improving health outcomes through collective problem solving. We harness information, convene stakeholders, and prepare action-oriented leaders. We act as an agent of change by empowering stakeholders. The current Queen Elizabeth Scholarship Program is run by a partnership between the Rita Hall Foundation, Community Foundations of Canada, Universities Canada, and individual Canadian universities. The purpose of the scholarship program is to activate a dynamic community of young global leaders across the Commonwealth to create lasting impacts both at home and abroad through cross-cultural exchanges encompassing international education, discovery and inquiry, and professional experiences. The current version of the Queen Elizabeth Scholarship Program that's offered here at the McMaster Health Forum is called Strengthening Health Systems. Our scholars will contribute to strengthening health systems and become part of our large and growing network of health system leaders. The Forum's current QES program has had 3 cohorts of students. The first cohort, that you can see on the screen here, comprised students who mainly went away or visited us in the calendar year of 2016. Our second cohort of scholars, which comprised 22 students, primarily engaged in their scholarship in the calendar year of 2017. The third and final cohort of the current version of the Queen Elizabeth Scholarship Program here at the McMaster Health Forum primarily went away or visited us in the calendar year of 2018. Today's presenter comes from the large group of incoming scholars who worked with us in the spring and summer of 2018. Today's incoming scholar presenter is Pippy, who's completing a Master of Public Health and Health Management at the University of New South Wales in Australia. Her work is looking at effective models of care and strategies for the prevention and management of chronic disabling pain in the primary care setting. Pippy hopes to draw upon the knowledge and skills she has gained in strengthening health systems to inform her approach to this work. Everyone, here's Pippy.
Thanks, James. Okay, so good afternoon, everyone. My name's Pippy Walker, and I'm a Masters of Public Health and Health Management student, and I'm also currently working at the Menzies Centre for Health Policy at the University of Sydney in affiliation with the Australian Prevention Partnership Centre. So today I'm going to talk to you about the project I'm currently working on as a researcher at the University of Sydney, looking at strategies and models for preventing or reducing the risk of the development of chronic pain in primary care. And I should also acknowledge my fellow team members back in Sydney, so Professor Fiona Blythe, Professor Andrew Wilson, and Dr. Samantha Robotham. So just a brief overview of what I'm going to spend this time talking to you about today. I'll start with an overview or a background to the context of chronic pain in Australia and lead into the aims of the project that I'm working on at the moment. The progress that we've made since it started only a few months ago, and then based on this progress, tie in some reflections that I've had over the past 3 weeks at the McMaster Health Forum in how some of the learnings we've had have informed my approaches to this work. Okay, so apologies for the busyness of this slide. I just wanted to get all the numbers up there, firstly so that you can see them, but also so it can prompt me to remember what everything is. So we know that in Australia the prevalence of chronic pain is about 1 in 5, that is encompassing of children and adolescents, and it has been consistent for the last 2 decades. We know that people that suffer from chronic pain have overall much poorer health, increased disability, decreased earning potential and participation in the labour market, and also a reduced quality of life. So quite significant social impacts on people that are suffering chronic pain. It currently costs the Australian economy $34 billion annually and is our 3rd most costly health problem, so that falls behind cardiovascular disease and musculoskeletal disorders. So if we think about this problem in the context of the health system, we know that actually less than 10% of patients that suffer from chronic pain are accessing what we would consider to be effective management. So what I mean by effective management is moving more away from pharmacological modes of treatment to more non-pharmacological options. So this primarily consists of a multidisciplinary biopsychosocial model of care with an emphasis on patient self-management, so engaging the patient in their own management of their pain. And these models of care have in most cases been shown to be more effective and are certainly the preferred mode of treatment when we understand the adverse events or effects that are associated with the pharmacological treatment options. We know that there's an overuse of opioids, and the effectiveness of their long-term use is really just not very strong in terms of the available research. As Kelsey alluded to earlier, we also know that there's certainly an overuse of other medical treatment options. So there's a lot of overuse of imaging, but also of surgeries to help manage pain. So we're really trying to increase effective management encompassing that biopsychosocial model of care and self-management. This could typically include cognitive behavioural therapy, pain education, and also physical and functional rehabilitation. So I've got some information there on opioid use, just following on from that. This information is specific to osteoarthritis. So dispensing it for opioid use for osteoarthritis is expected to triple by 2030, with associated healthcare costs expected to increase from just over 25 million Australian dollars in 2015 to over 72 million Australian dollars by 2030. So it is a serious concern, both from a patient outcome point of view, but also from an economic one. We know that the dosage of opioids being used is associated with access barriers to non-opioid or non-pharmacological treatment. So when I say access barriers, this is a combination of both actual supply barriers, so the availability of effective management for patients, but also a financial one and patients' ability to pay for more effective methods of treating or managing their pain. There is certainly plenty of literature out there to describe patient experience with the primary healthcare setting. This particular study described patients' experience with primary care as having poor access to information and services, inadequate knowledge and skills among practitioners, and certainly feelings of isolation and frustration. So essentially the issues relating to chronic pain are a product of both poor community and primary healthcare provider understanding of pain. And given we know that there's long wait lists and inability for specialist services to meet the current and future predicted demand for chronic pain, the primary healthcare setting is certainly the current key focus in terms of solving this health system issue. This is just to provide a little bit more detail on the opioid issue in Australia. So this is a map of Australia, and it's colour-coded by the number of opioid prescriptions that were dispensed in 2013-2014. Apologies, the colours haven't come out very well on this, but generally the lighter colours are the higher prescribing areas and the darker the blue colour gets are the lower areas. The difference between the highest and the lowest area is 10 times. So some areas have 10 times the rate of prescribing opioids than the lower areas. And you can see that the lighter areas tend to be areas that are less populated, more rural, remote areas that generally have less access to healthcare services, and also carry a higher proportion of our Aboriginal and Torres Strait Islander population. So it's generally thought that the areas with higher prescribing are those that have less access to non-opioid options for managing their pain. Okay, so despite all these problems, there's certainly been plenty of ground being made, particularly over the last decade in Australia. So I just want to talk you through some of the strategies, programs, elements that have been implemented to try and address this problem and then lead into where our project fits in. So back in 2010, in the top left of that screen, we released a national pain strategy, which I believe was actually the first national pain strategy to be released on a global scale. And this had a number of key action areas of priority to be addressed. One of the first ones of which was to establish a key body, and that was Pain Australia that's in the middle there. So they're a national peak body working to improve the quality of life of people living with pain, their families, carers, and to minimise the social and economic burden of pain. So it was primarily, or they were heavily involved in actually implementing this pain strategy. They have a broad representation of membership, so both health care providers, medical providers, but also patients and consumers. A couple of the other key priority action areas were ensuring knowledgeable, empowered and supported consumers and also skilled professionals. So a couple of initiatives that have been in line with that, and of course these are just a few examples, there's obviously been much more done than this, but down the bottom the Pain Management Network is a website that has quite detailed and really helpful and useful resources for both providers and patients. It talks providers through how to assess and manage patients suffering from pain and service availability, and similarly for patients talks them through self-management strategies and where to find more information. Also in terms of professionals, there's a number of initiatives up there in relation to pharmacists. So there's a Meds Check program which allows pharmacists to identify patients when they come into a pharmacy that may benefit from additional support with ensuring that they're using their medications appropriately to manage their pain. In addition to that, quality improvement and evaluation was an important element as part of the pain strategy. The electronic persistent pain outcomes collaboration is an example of this. This is essentially a benchmarking data collection, a source of data collection of a standard set of data items and assessment tools in specialist pain clinics and services across Australia and New Zealand. So this essentially captures all the information on patients being referred to specialist clinics and provides really important information on wait lists, but also rates of opioid prescribing and also patient trajectory in terms of the outcomes when they're undergoing specialist treatment in these services. In saying that though, this service is not implemented in the primary care setting, so we're not currently really picking up anything of this kind of level of usefulness in the primary care setting in relation to patients with pain. What else haven't I addressed up there? I think that's just about it. Lastly, up the very top there, this is the most recent initiative that's been implemented. So as of February this year, codeine products have been up-scheduled, so patients can now no longer buy codeine-containing products over the counter. They must have a prescription. And whilst the article that's been added in there, it shows that the AMAs, the Australian Medical Association, are in support of that, and a lot of health professionals were in support. There certainly had been a bit of backlash from patients that were heavily relying on codeine products to help manage their pain. So the government really took this on board and understood that more needed to be done to continue to look at this health system issue and how we're addressing the problem of chronic pain. Okay, so that sort of leads into this project. So although much has been achieved, there still was this sort of gap in the primary healthcare space. So this project was announced early this year. Around the same time codeine was up scheduled, the federal government provided significant funds to conduct research into looking into how to tackle the problem of chronic pain from a primary care perspective. So the aim of our project is to identify achievable, sustainable ways to improve pain management in primary care and prevent people from progressing from acute to chronic pain. So essentially what we're doing is looking at care models of early intervention that work, so identifying models that work, and what resources are required to actually support the implementation of these models. So we're approaching this work in three phases. The first phase is essentially a lot of searching and collecting of information of what's out there, both in terms of the literature but also talking to experts in the field with knowledge of perhaps other programs and initiatives underway that haven't been published as yet. The second phase is actually to somehow synthesize all that information into a support tool that can be used by our primary health networks, and I'll describe them in a moment. But this tool will be a decision tool to allow primary health networks to identify what models of care or what strategies would more likely work in their own settings and be something that they have the resources to actually implement. Then the third phase is to actually work with our primary health networks to pilot the use of this tool to ensure that it is actually useful for them in helping to address the local needs of their community in terms of chronic pain. So our primary health networks, or PHNs, are federally funded organisations that essentially work to support primary health care providers. So they're in a really key position for implementing anything in the primary health care space. That map of Australia there shows you the geographical area of our 31 primary health networks that cover the country. Our population is very dense on the east coast, so we have a higher number of primary health networks covering that larger population. And then in some instances, states or territories may just have one or two primary health networks covering the whole area, which of course has different strengths and difficulties that come with that. You know, they're trying to manage the primary healthcare setting of quite a large geographical area, whereas others have very dense and high populations that they're looking after. So where are we up to with this project? Essentially we're at the very beginning. So our first steps were to establish a steering group and meet with other key stakeholders that are involved with program implementation in the space of chronic pain. Then we're also at the same time scoping the literature to identify what's already been implemented and evaluated in the Australian context. So for me, this was very much the first time I've ever been faced with looking at a national health problem. I've usually worked very locally or clinically in one specific setting. So for me, this is just my own personal reflection on some of the barriers I've faced with approaching this work. It was massive. You know, there was no specific, one little element to this health system problem that we're looking at. We're basically trying to cover everything in one project. So some of the things that I came to McMaster still grappling with was certainly the breadth of the problem and how I bring all of that information down to something of value to hand over to our PHNs to help them improve the primary healthcare setting. The diversity of possible solutions that could potentially be implemented to solve this problem, and also blending that in with our stakeholder priorities. So our steering group are such experts in the field of pain. They have so many possible options and ideas of how we could solve this problem, and I just found it nothing but overwhelming, to be honest, because I have to think about how to actually categorise that and make sense of it. Then also I've constantly been toing and froing with making sure that whatever we're doing is useful for our end user, and understanding perhaps what our PHNs have most authority over in terms of what's feasible for them to actually think about, and perhaps what other strategies should really be more left to government because they have more authority over certain arrangements. The other thing was also deciding how to communicate the findings from the literature. So how do I sort through everything that we pull out and categorise it in a way that's actually going to be useful to inform the development of the tool in stage 2 of the project. So in taking that, I have my own personal reflections on how the work that we've done at McMaster over the last 3 weeks has helped me here. And I first just really want to acknowledge the incredible team at McMaster for their commitment but also their patience over the last 3 weeks to really ensure that we understand the frameworks that we've been taught but also understand how to apply it to our own local health system problem. It's been an incredibly valuable experience and certainly time well spent. And whilst I'm sure that I can apply all of the things I've learnt to both my current and future work, I've just picked out a few that relate to the barriers that I mentioned before. So certainly the taxonomy of health system arrangements really was just like a Bible to me in my eyes with the problems I was coming to McMaster with in my own project. So it helped me immediately start to categorise all the different possible options that could be used to address chronic pain, and also identified new ones that I hadn't even thought of. So that was really, really nice to see. It's also provided me with a framework to start to sort through all this literature that I'm finding. I really think that, say, all the different types of delivery arrangements will be a really great way to think about what's already been done and what areas have tried to be addressed already. And it's also helped me to understand what PHNs do have authority over, and like I was mentioning before, what the government may be more inclined to look at implementing themselves. So in this instance, certainly delivery arrangements is where PHNs would have their authority, whereas any more governance or financial arrangement strategies would really be something that government would have more authority over implementing. Also, the finding in using research evidence methods. I found this was a realistic method for identifying all the evidence that I need for this work. Again, like I said, the breadth of the problem, I was so overwhelmed with how I do an in-detail literature review for every single thing that might help fix chronic pain. This was such a useful tool in using the health systems evidence database, and the methods that everyone at McMaster here follows has just been invaluable for me to understand, and I really look forward to taking that home and informing my work. That's it from me. They're my references. Thank you very much again. I've also really enjoyed meeting everybody here, all the fellow QES scholars, and I hope we can keep in contact into the future. Thank you.
For those of you who are able to make it here today to watch the presentation in person, I want to thank you for coming out. For those of you that have watched the video later on YouTube, thank you very much for taking the time. Before we leave you today, I just want to take a minute to go over a couple of the links that are on the screen to provide you with additional information about our program and what our scholars have been doing. If you're interested in the Forum's Queen Elizabeth Scholarship Program, either the current program, which is ending in 2018, or the new program, which is actually being launched in mid to late 2018, I would encourage you to please click that first link. That will take you to the information page at the McMaster Health Forum's website and tell you all the information you need to know about our Queen Elizabeth Scholarship Program in terms of how to apply and how to be involved. If you're interested in other presentations and webinars by our Queen Elizabeth Scholars, I would encourage you to click on that second link. There you'll find all of the current webinars that have been done by all of our Queen Elizabeth Scholars, and future webinars that our scholars will be doing will also be posted there. And thirdly, you'll see that there is a link for our scholars blog page, which is MacHealthForumScholars.com. Our scholars write blogs about personal reflections about their experiences while abroad or when they visited Canada if they were an international scholar. So please visit that page and read some of the blogs that our scholars have posted. Feel free to follow us on Twitter at MacHealthForum, and please follow the hashtag QEScholars so you can see all of the fun and exciting things that scholars have been doing from multiple universities around Canada. Thank you for joining us, and we'll hope to see you again soon.